Welcome to the office. Welcome, sir.
Well,
Nice to meet you.
nice to meet you.
Tell me, what brings you to the office?
So a couple complaints. I'd say the first one is right low back,
Okay.
followed by chest,
Number 2.
knee, just out of concern of the surgeries,
Okay.
and then right shoulder.
Right shoulder. So back, chest, knee, right shoulder. Let's talk about the back, or which
Okay.
one is number 1 for you? What's the most important?
Let's say the low back.
Low back, tell me about it. What happened?
So I don't know what happened exactly. Obviously, it's more present when I was more active and actually going to the gym.
Okay.
But it feel like just really tight and restricted in here.
Okay. On the right side?
Right
in
side
the
specifically.
Center or to the...
More toward the right.
Okay. To where the dimple is?
I'd say a little more to the right.
A little further than the
Yeah.
dimple. Okay. And it started when?
I don't know exactly, to be honest with you. I don't know if it was from the initial knee surgery when I was hobbling on it, or the injury, to where over time it just made the back pain worse.
So what happened first then? The knee?
The knee.
Tell me about the knee then.
2009,
Yes.
high school, slid into second base, tore my meniscus.
Baseball.
Yeah.
All right.
Surgery, and so injury happened in February. I wasn't able to walk at all. I was hobbling on it.
So you slid into second base.
Mhm.
This was high school, you said?
Yeah.
High school baseball.
Right.
Cool. Slid into second. You landed. You did exactly what when you slid?
Just a normal slide,
Yeah.
kind of a pop-up slide.
Yeah.
And then obviously this knee was on the ground, this one came up, and it just bunch of
You heard the
tears.
pop?
Oh yeah.
Tear?
Yeah.
Okay. And what did they find and what surgery did they do?
Well, the high school trainer couldn't really find anything because she was doing all the, I guess, orthopedic tests to it.
Uh-huh.
She didn't find anything that
No
was a tear.
ligament instability at the time?
No, not at the time. So then we didn't do emergency room. We just went to a local chiropractor.
Okay.
They did the same test. They didn't feel anything. They were like, okay, let's just rehab it.
Okay.
But the knee was locked. I couldn't straighten it at all whatsoever.
Okay.
Whatsoever.
Okay.
So I was walking like this.
Got it, yeah.
So a couple weeks
That's
went
a
by.
piece of the puzzle, by the way. Okay.
I'd say 2 to 3 times of chiro and physical therapy at the same time, to where I was able to straighten it and run again.
How long did it take?
Several weeks. 'Cause I was
Several, 3 weeks, 5 weeks,
maybe 4.
3, 4 weeks?
So that's like 3 days of physical therapy and chiropractic care.
Okay.
So they got it to where I can run again, played baseball again,
Okay.
slid, locked again.
Same
Yeah,
second base. Don't tell me it was second
it
base.
was second base.
You stealing first too much. That's the problem. Okay. Sorry.
So the same thing happened.
How long after?
I don't remember. It was back in 2009.
Tell me it was a
though.
different team though.
No.
Same
It was,
team?
it was during the same senior.
No, you were playing a different team or
Oh,
same
yeah.
team?
Different team.
Okay, I'm just making
Well, the first
sure.
one was practice.
Okay.
So.
Sorry, okay.
So the second one was during a game.
What happened when during the game you slid?
Yeah.
Same thing happened on the
Locked
left
up.
knee, locked up in this position.
Yeah, couldn't straighten it out.
Okay, then what happened?
Same thing. Went
What
back
did you
to
do?
chiro, physical therapy. They rehabbed it again
How
until I was
many
able to
weeks?
walk. I don't remember, but by the time the third time happened, I was.
What do you mean third time? Hold on. Okay, so second time it happened.
Yeah.
Chiro rehab 2-3 weeks, 1 week.
Maybe 3 or 4.
Okay. Unlocked then.
Yeah, unlocked.
Running
Able
again.
to run. Yeah.
Okay.
So then.
Playing baseball.
No, this was after.
Okay,
So
baseball is done.
summer's done. Yeah. So we're into summer now. Maybe July.
Okay.
Getting out of bed.
Yeah.
Got out like this.
Same thing.
Same thing.
What is that telling you? Seriously, what does that tell you? You know everything is connected,
Yeah.
right? So if that knee keeps going out the same place, the first 2 times doing the same thing,
Mm-hmm.
what is that telling you?
Should have done something a lot longer instead of waited months and months and months.
Well, what else is it telling you? To me, it's telling me it's coming from somewhere else, mechanically, because it's all connected, right? This is formed. The knee is formed by the femur and the tibia. Where does the femur connect to? The hip. The hip is part of the pelvis.
Mm-hmm.
Pelvis is connected to sacrum, back to the spine. And the reason I'm saying that is you're this recurring injury, and after the first rehab, You know, if you were strengthening, everything was good. You were getting adjustments too, right?
Yeah.
Do you know what you were getting adjusted? Do you remember?
I think it's just mostly neck and probably back. I think they were doing like the side.
So you don't actually know what you got adjusted?
No,
You were just
it was
getting
so long ago.
Okay, fair enough. Okay, so after the second one, rehabbed it, summer's over, what
Right.
happened?
Just got out of bed,
Yep,
the same position, went
Yep.
like that. Happened again. So then we finally went to get an MRI. MRI showed a tear, meniscus,
medial or lateral?
lateral, I believe.
Lateral
and then
meniscus.
50% ACL
Okay, 50% ACL what?
tear.
Tear.
Mm-hmm.
And lateral meniscus.
Yeah.
How about the lateral collateral ligament?
I don't think they mentioned
LCL
anything,
was
no.
fine, right?
Right.
Okay. What did they do then? What was the
Well,
procedure?
I thought I got a meniscus repair back in August of 2009,
Okay,
but it may have just been like they may have shaved it.
okay.
And
Little arthroscopy?
Yeah.
Okay.
So then it's good up until September of 2020.
Okay, right on.
Right. So
But you're not playing sports now.
no, I'm still active and stuff like that. Well, because of the shutdown and the gym's closing, not as active.
Sure.
So September 2020 comes, I'm doing yoga at home. I'm on the ground like this, and I get up to turn. This knee stays against the floor, and my body turns right, and it tears again. So
Interesting case. Okay.
November 2nd, 2020, get the lateral meniscus repair. And I just was labeled as healed yesterday with the ortho.
And then you show up to me?
Perfect timing.
So you already had an appointment booked though in advance, right?
Yeah.
So the timing actually worked out.
Right.
So ortho cleared you?
Mm-hmm.
Everyone cleared you.
Ortho did. He just said, "You're resumed to do everything. Just whatever you do, just start slow."
What am I
Back into-
supposed to do for your knee then?
Well, I was concerned that there
Why
was
are you
some
here?
twisting in the femur and the tibia
Okay.
because I was looking at the X-rays too, and the joint spacing looked off to me.
Okay. How do you know that?
Well,
You've
that's
been
all
watching
once a year
videos,
because
right?
yeah,
Okay,
exactly.
very cool. What are you doing right now? Working? School?
Just
Okay.
working from home. Yeah,
Okay. All
so a
right.
lot of sitting all day.
A lot of sitting. What are you doing for activity?
Well, I'm gonna start jogging pretty soon because I just got cleared.
Okay.
So that's
Jogging
what I-
is not indicated. You will not start jogging soon.
okay.
I will explain why, please.
Okay.
Okay. You're okay the way I speak, yeah?
Yeah.
Okay. All right. I'm just making sure. Well, I'll explain. Jogging is not indicated. You're going to tear something again,
Okay.
and it's not going to be your knee this time. Okay. I'll explain. Jokes aside.
Okay.
All right. So you're here to get evaluated then for obviously the spine
Right.
and all that. In relationship to the knee, we're going to talk about the knee. I probably wouldn't touch the knee on your first visit here. You just got cleared yesterday.
Okay.
The other reason why there were things I'm sure that were not assessed related to the knee. One is the foundation.
Mm-hmm.
Yeah. Second are nerves that come from the lumbar spine. There's a little mnemonic we learned. L3 to the knee, the testis, and the ovary in females. So we need to check and make sure that all those nerves are free and you're getting good power there.
Okay.
That's the knee. The back, the shoulder. Tell me
Okay.
about the shoulder.
Shoulder, I know, is a specific incident. It was a couple years ago. I was bouldering,
Yeah.
indoor rock climbing.
Yeah.
I went to reach for another move and I slipped with my left hand, but I held on with my right and it twisted. And ever since then, I knew right away something was wrong because of sharp pain,
Okay.
like I strained or sprained something.
Okay.
Chest, it's a sharp pain, mostly on the left side.
Okay.
And, I don't know if the incident in 2014 was the actual start of it, but I was just walking down the street and I felt sharp pain. So I went to a local doctor. I think they did x-rays and like a normal exam. They didn't see anything. They said it was fine.
Okay.
A couple years later, it came back. I was just sitting on the couch. And this is after I was already going to the gym and stuff, so I don't know, maybe I strained something.
Okay.
Sharp pain right in front of the
Center
chest.
in the sternum or towards the edge where the ribs attach?
Ribs attached.
Okay.
Sharp pain. So then went to the local chiropractor a couple days later. She told me that it was rib head misaligned. So she did like more of a lateral adjustment and the pain went away.
Cool.
But it's pretty much there occasionally to where if I'm doing push-ups, I can feel it. If I'm like washing dishes, I can feel it, and it's still there.
Okay. So your chest is okay now?
Well, I mean, the bump's not there, but
Okay.
like I said, if I'm doing push-ups or something or
Yeah.
constricting my chest, I can feel the sharp pain right here.
Okay, but the bump's not there.
No, not from. No,
Okay.
I don't feel it right now.
Okay, no problem. So we need to evaluate you, see what's out of balance.
Okay.
We're gonna obviously start with foundation, right? This work is based on the foundation principle. Everything goes back to that. We will do the gait analysis, we'll go over your x-rays.
Okay.
We'll do the exam, we'll figure out where we're gonna start today. Fair enough? How about the nose?
Sounds good.
And the jaw is off too.
Yeah, I noticed that when I open my mouth, kind of shifts.
Yeah, we'll deal with that. That's not the primary reason you're here, but we'll deal with that along the way.
It's fine.
Okay? And as I said for today, I'm not touching the knee today.
Okay.
You feel the knee though right now? Like in terms of whatever's going on with it at the moment? Is there discomfort? Is it off at all? Or it's good?
So it's fine like every day walking and sitting. It's when I bring it up to stretch that there's a little bit pain in the back and like on the side.
Okay. Anything else? Otherwise we're gonna get started.
A lot of clicking. Back and
Mechanics,
forth.
imbalance.
Okay.
Okay, so we need to figure out where we're gonna start today.
Okay.
Got it, okay. All right, you ready to get started?
Let's go.
Let's do this. And what's interesting in his case is there's a transitional segment where there's 6 movable lumbars. That's number 1. Yeah. And we're doing his posture assessment as well, which is a little different because normally we're doing it off the lowest lumbar, which is typically L5, 228. So I'll show you we're doing it off of L5 and L6, 230. Okay. P1 dash R, 228, 2 millimeters. Yeah. All right, so we have an AS. Hold on. AS2, EX2 on the left, slight rotation on the right, but I'm not so excited about a rotated sacrum on him. What I am seeing is there's a bend in his tailbone. It goes like this, and it's right there. And that's it right there, sir. That's the start, and that's what I circled right there, the nub. And I'll go through all this. I'm just showing you this, okay? From there, let's do the level foundation. And we're taking this as our level base. First one to go off is L5. 4 goes with it, 3 goes with it, 2 goes with it, 1, 12 comes back. Next one, 11. 10, 9, 8, 7, 6, 5, 4, 3. Next one is going to be, 2. And then 1 goes off. So 1T, 11T, 5L, S3, S4, transitional vertebrae. And now let's look at the top. We have a TMJ deviated. It's also a little misleading here. And I want you to take a close look at the capsules of his atlas. And the capsules of his atlas have been wearing out. You played hard, dude. You played hard. You didn't mess around. Okay, we'll talk about that. And we got this, 60, 60, 60. We got that. We're ready to go. Now, we have typically, there's 24 bones in the spine, 23 discs in between. There are 7 movable bones in the neck, cervical, C1 through C7, 12 in the mid-back called thoracics, T1 through T12, 5 in the low back called lumbars, L1 through L5, and then we have the foundation, which is the sacrum and the pelvis. And the first thing I need to point out in your case is this. We have a transitional segment. Now, what does that mean? And it's in 10% of the population where, and it's in 10% of my cases or more, where the person either has 4 lumbars that move or 6. And what does that mean? It means that it developed different. That's all that means. So you had a lot of flexibility growing up too. I think you were a little more flexible than some of your teammates. I have a feeling. Sound about right?
Yeah.
Okay. And that's why. So now when we look at it, what does it mean? Someone who has 6, I labeled it L6, S1 as a transition. That person needs more back strengthening down the road. Someone who has 4, they need more flexibility work. Does that make sense?
Right.
Okay. Now, let's go over the foundation. We have the numbers show AS2, EX2, P1-R. This is the thing that stood out to me, is down at S4. If I look at the foundation, this is what's happening. The left pelvis goes up and slightly out. The sacrum on the right goes slightly to the right. It's subtle. It's very light. But here's what's interesting. Your foundation wants to go to the right. Your spine wants to go where? Left.
Mm-hmm.
That's your disconnect. Now, the fact that we have 2, we'll figure out, because you're complaining of one side more than the other. When we have 2, we'll figure out which one is more stuck, swollen, and going to give us the best result today. Okay? Now, from there, let's go over the level foundation. And from here, if we take this as the lowest, the first one to go off is going to be 5. And L5 goes off of its foundation, 4 goes with it, 3, 2, 1, 12 comes back to level. Next one to go off is 11, and that's that whole compression fracture you forgot to mention to me. You played hard, dude. Okay? Baseball, right?
Yeah. Skateboarding, lots of stuff.
Skateboarding.
Yeah.
Okay. 8, 7. Now, here's the good and interesting part. This whole mid-back is compensating from your T11. Okay? T11 takes everything up all the way to T2. And the next one to go off is T1. And then from T1, that's where you're getting the straightening of your spine that you were told. Okay? Does that make sense on this x-ray so far, the mechanics?
Yes.
Okay. Now, digestion. This is the gastric air bubble. Should be like this. Nice, dark. Half a moon. We got a lot of undigested food in your body. It's not what you came in for, but we'll talk about that along the way. Okay, fair enough?
Yep.
Okay, let's go over to this x-ray and let's talk about your posture. When we're assessing posture, the first thing is, they do a plumb line at a lot of gyms and physical therapy offices, and it was a big thing back when I was in school. We all used to do this weighted string plumb line. I don't know if you've ever had that done.
I don't believe so. No.
Okay. I guess it's antiquated now. So we take the lowest lumbar, typically would be L5. In your case, we're taking 6. We run the laser level up, and this is what we see. If we take 5 as your lowest, this is where your posture is. If you take L6, it's here. Regardless of this, the thing I need you to see is your upper body here is behind your foundation. With it being behind the foundation, all these muscles are going to work overtime just to hold you up. So I know when you're sitting or standing a long time, you're starting to get stuff across your shoulders here. Correct?
Yeah.
Yep. Okay. And that's the reason why. Now, next thing is the curve. You have good curve in your low back. Good stuff. Okay? But something around here is what's throwing off the rest of the upper body. So yes, you were told you don't have curve. You need the curve in your neck. It needs to be going forward. But guess what? And you came to me with a neck x-ray only, right?
Yeah.
So someone who has a straight curve, straight neck, this is important information. Someone who has a straight neck based on just a cervical x-ray, it's not telling you anything. You need to evaluate everything. It can be coming from T11. It can be coming from the right sacrum. It can be coming from a cuboid for that matter. Okay? But the good news is your discs are good.
Okay.
Your discs are good. This one is wearing out a tiny bit more because it's straight and it looks like it wants to start going in the opposite way. That's probably where you get your cracks and pops. It pops and crackles a lot, yeah? And then if that's not stable, the atlas doesn't have anything stable to sit on. So then the head starts to hurt. And then the muscles start to get tight in the suboccipitals right about here. Sound familiar?
Yeah.
Okay. And that's all just from looking at it, right? Now, let's go down to the tailbone. That was the big nub. That's the big nub. And that's probably, like I said, where we're going to start to balance the sacrum. Once that's sorted out, in a transitional segment, depending on the movement, but the other thing I circled here is this, right? There's space in there. So that remnant disc of the S1 is now, it hydrates and it swells and it can cause pressure. So if it needs to be adjusted, we will adjust it.
Okay.
Okay? Questions? I know it's a lot of information, but
So
you're
far,
getting
so
the,
good,
you're
yeah.
getting the gist of it, right? Okay. Now, this compression, old compression, that's another thing we need to deal with. And in the Gonstead work, there's a whole case class we do on just compression fractures and how do we manage them. And they're actually, this work is fantastic for managing compression fractures. This is old, it's healed, okay?
Okay.
That's old and healed. In your scenario, typically with the compression, you're bringing the one below to it. It's been there at least 10 years, dude. Okay. You played baseball how many years?
I mean, probably since I was 5 to 18, 19.
Now let's go to the shoulder and talk about your shoulder and clavicle, okay, because that was concerning you. The shoulder joint is the only joint in the body under 100% neurological control, and it's important what I'm about to say. So they did a study where they severed nerves going to different joints in the body, and they did this in animal studies, not in humans. And they severed a nerve, let's say going to the elbow, it still stays, or the wrist, it still stays. But when they severed the nerve to the shoulder popped out. And why that's so significant is this, that we know the rotator cuff muscles are there, the sits muscles, absolutely, and they're holding it there. But they're under constant communication and power from where? The lower cervical spine, okay? So the reason I say that is every shoulder case I've dealt with in 18 years, I always start here, okay? And we'll go through the mechanics. And that's part one. Part two is this kink. And this kink is doing this, look. So, these are the vertebrae, yeah? We're looking at these pedicles here. This one is smaller, this one is bigger, yes?
Yeah.
Smaller, bigger, smaller, bigger. It's twisted. And it's starting at T4, T5. See how T7, no, it's starting at T7. T8, they're more symmetrical. T9 are symmetrical. T10 are symmetrical. T7, it starts to twist. And it's twisting this way to the left side. So it's doing actually this. Here it's doing this. It's turning. Okay, so it's coming back, coming back, coming back, coming back, coming back, coming back, and then it's switching sides. So this part of the spine here, it's actually coming back like this. Okay, so you're feeling that this looks like it's more pronounced. Does that make sense?
Yes, it does.
And that twisting is why the rib head is not right. And it's starting at T7, so it was probably a T7 rib she did, I'm assuming, somewhere in here.
Okay.
Okay? But all of them are twisted up that can potentially pop those out or make them feel sore. Make sense?
Yeah.
Okay. Questions on the x-rays?
No, not at the moment.
Okay, shall we continue?
Yeah.
So, we're looking at AP comparative knee. You were weight bearing for this, as it says weight bearing comparative. This is right, this is left. I don't have my measuring tools on this, but that's okay. I want to go over some basic things. What we're looking at is the overall appearance of it, and we're looking at the patellas here. There's the patella. Patella. This one's out more lateral, yes? This is the patella. We draw a line here, we draw a line here. Let's say the line goes through here. Patella is out lateral. They're out lateral on both sides, but more lateral on the left side. You can see the tib-fib space right here is closed versus this is open. That's due to posteriority of that tibia and possible fibula. It's rotating back. Let me go grab the knee model and I'll explain. This is the right side, and I only have a right knee model, but I'm just explaining. This is the tibia, that's the kneecap, that's the femur. Interosseous space or interosseous membrane right here, fibula sits there. This is optimal alignment. Optimal alignment, we have proper tracking of the patella. We get misalignment of the femur this way, we get a click or a pop. We get misalignment of the tibia, we get clicks and pops. We get misalignment over time, we get uneven wear and tear of the disc and the meniscus. Basic mechanics. It's like the alignment of a car, right? And what happens when your car's out of alignment? It starts to go one side, you're pulling it the other, the tires wear out unevenly. And the same thing happens in the human body, in the joints of the human body. So I want to explain. Everyone's like, hey, I gotta plug this thing. I get so many, and guys, don't take this wrong. I get hundreds, if not thousands of emails every month. Do you fix this? Do you do this? Do you do that? Can you help me with this? Can you help me with that? So the thing I like to say to everybody is, my job here is, if you're producing or having these symptoms and imbalances, my job is to help you find the balance. And if it is due to nerve pressure or imbalance, then what happens if we fix it? It should get better. Right? But the point I'm making here is, whatever the imbalance is, we get it back in balance and the body should do its job. Yeah? Okay. So looking at it from the front, this, if it's gone back, watch this membrane here. If it rotates back and we're looking end face, it's going to appear smaller. All right, it appears smaller. It's a closure of the space. That's here. Left one, and patella is out. Now, here's another piece of the puzzle, sir. Look at this is called enuberation, whitening of the bone. It can be anywhere in the body. What that tells us is there's more stress on that part. So this is the right. You're favoring what? The right side. Okay, just looking at this. There's more whitening here than there is here. Yes?
Yes.
Okay. And you said the surgery you had done on the?
Left.
So that also makes sense that you're favoring the other side during the rehab and all this. Okay, but I need you to see it's still not aligned. Okay? Now we look over here. Here's the other piece of the puzzle. The good news is you have your superimposed medial and lateral condyle. They did a great job. Okay? That part's good. We have a posterior fibula. This fibula should be superimposed on the side of the tibia. It's not. So mechanically, what does that do? It affects the knee. It actually affects the ankle and the gait. Okay? And we'll see that in your walk, I'm pretty sure. Does that make sense?
Yeah.
Okay. So we're not touching this right now. Okay? Well, I'll evaluate it all in the next visit for you. Okay, sir?
Does that explain the knee clicking ever since the first surgery?
Yeah. It was an alignment. And this is why it's so important, guys. Get checked. Even, I will always plug children getting checked. It doesn't matter what they do. You're playing, we're falling, we're having fun. My daughter's falling every other day right now. She's getting so active. And Daddy, my thumb hurts. Daddy, my knee hurts. Daddy, my this hurts. And I hear it so much, so I have to check her more. Those are all falls we had as kids that parents, you got to get them checked. Whether you're coming to me, somebody, but get it checked. At least get an x-ray of it. And I've taught you guys so much on how to evaluate it, even just to look. Does it look right? That's my little educated tangent. Come over here, sir. All right. So first thing, let's look at mechanically. That's swelling. That needs to go. Number one. Number two, right side is higher, left side is lower. He's got a lot of swelling in his body. This is all swelling. Okay? All this. And it's starting down here. So we said right side is slightly higher, left side. You can also see there's some dishing in here. This is what I was showing on x-ray. There's dishing. He's got the double dish. There you go. Okay, so from here, right shoulder is higher, left shoulder is lower. He's hiking up like this. If we look at his feet, his right side is externally rotated a little bit. We're going to now watch him walk, and I want you to go to the nervous system posterior and back, please, several times. And let's watch the dimples. This should be moving up and down. Let's put a little mark on it so we can actually see it. All right. Do-do-do-do-do-do-do. All right, senor. Let's walk it out.
All right.
You coming from Brea, you said, right?
Yep.
All right, let's walk. So he got a Brea tinkle going on. Nothing's really moving down there, dude. It's very stiff. I don't see any of this action. Do you?
Mm-mm.
All right, so watch this. This one's a little bit higher than this one, but I don't really see them moving up and down that much. Walk. I see the left one just going out to the side. So I see a little bit of this action. Okay? Have a seat, please, and let's get started. All right, starting at the base of the neck. Head down, please. And it's subtle. It's actually starting up top. 7 points, left side. There's a tiny one hiding right there. T1. It's like a 3-4 pointer. Did you see? Now, this is another interesting finding I want to teach. To teach is to learn twice, guys. It was taught to me that way. So every time I'm teaching, I'm learning with you, okay? I'm a big advocate of that. So it doesn't matter what you know in any industry or subject profession. Teach it if you want to own it. Mira. 11. All right, sir. Let's go digging down low now. S4, sir. Right down here. S4, T11, T1, C1. All right, feet together. Open and close your knees, please. Open and close. Feet are touching. Slide forward a tiny bit. Feet together. Open and close. Both of them. Good. Good. Right side only. Good. Left side only. I'm not too excited about your pelvis today, sir. Scoot back for me, please. Let's take a look here now. L5. S1. That's L6 though. You feel that?
Oh, I feel it.
Yeah. But that's not your issue. S2. Pain?
Yeah.
Tender.
Mm-hmm.
More than L6. I'm going to just call it S1 for right now.
Okay.
S2.
Oh, yeah.
Let's go down. S3.
Not as much as S2.
S4.
I think S2 is the worst.
Got it. Okay. I got to dig because there's a nub right there. I need to just make sure, okay? All the way. Right there. Do you feel that, sir?
Yes, I do.
Now, that's S4, okay? I know S2 is tender. We may need to deal with that later. I want to start down low, though. And the difference is this is acute, but look, I have to take it. It's an old injury is what I was saying right there. Do you feel that, sir? Right side? Not as bad?
Left side's worse. Right, I still feel both of them, or
Okay.
all of them.
Okay. Head down, please. Static palpation. We're sliding the fingers down the spine. Digital palpation. Right when we get about there, it changes. It gets boggy, orange peely, and it sucks in right there. Top one, right there. Yes?
Yep.
1, 7, 1, 2, 5, 6, 7, 8, 9, 10, 11.
Fracture.
Compression. Compression was, it's sandwiched.
Oh, okay.
6, 7. Yeah, one's not moving. Okay. T1 is what I was referring to. Yes?
Mm-hmm.
C1. Left side. Now, we have an upper cervical, lower cervical, or upper T. We're going to do divorce test to determine where we're going to start. Look up. This is isolating the lower cervical, upper T. It's tight there. That side is okay. Yes?
Yeah.
Head down, please. Upper cervical. It's tight there. It's tighter there. C1 on the right. Sit up straight, please. C1, S4, T11. That's my thought process for you for today.
All right.
Question.
Ready whenever you are.
Let's rock and roll then. We're going to start here with your C1. Right ear, right atlas. So nice soft pinch of the SCM. C1, ASR. No. It's not happening there. Not enough capsule. Let's go over here, please. Face down. We'll do everything here. ASR atlas. Right hand here, please. We got to get some movement there. And that's the home run, brother. Nice. Head down, please. L5, L6 or S1, S2, S3, S4. I got you, sir. S4. The elusive S4. There it is. Nice and easy, sir. Good. Bring your chin up a tiny bit. That's a piece. That's the home run. Gotcha. Thank you, Shesha. Walk it out, please. What's different as you're walking, sir?
It feels less restricted in the lower back hip area.
We forgot one thing. We forgot to stretch that leg. Bend the leg back. Can you bend the leg for us?
Sit down and do it? How I do it?
However you do it.
Still pretty tight, but it's
Is it
easier.
Is it any different? I'm looking for different. If it's not different, it's okay.
I would say there's a little bit less pain, but it's still restricted to put all my weight down.
Okay, and you're feeling that restriction on the back side of the knee on the left.
Right here, I would say, yeah. Right here.
You know you're going to make me do your fibula, right? Come on over here, sir. Let's do T11 next. We're doing the knee chest table. Now, 5, 4, 3, 2, 1, 12, 11. Nice and easy there. Thumb contact, thumb piezoform. There it is. And that's the home run, brother. Like butter, baby. Yeah. Good.
Feels smoother.
Yeah, we're walking smoother. Good. Just humor me and go back down on the floor and see if that changed anything. That should be a little different.
It's a lot easier. I'm putting all my weight down actually right now.
Pretty crazy?
Yeah.
Anything can cause anything. Have a seat. That's crazy. T11. Ah. Look at how he's sitting now. Mira! That neck should feel very different, sir. Turn your head to the left. Nice. Turn to the right. Check it out. Yeah. Look up at the ceiling. Dude. Up to the left. Up to the right. Down at the floor. Down to the left. Down to the right. Look at that. Nice. T11 is clear. Clear. Check it out. Check it out now. I want you to feel this. This is 5. Yes?
Yeah.
That's 5. That's 6. Do you remember 6?
Yeah, I remember it quite well.
What does that feel like now?
Less pain.
Didn't touch it. S1.
I feel like I have more movement.
Sorry. L6, you have more movement. Or S1. Let's go down to the one you said was very tender. Come on, dude, really?
What?
Look.
Yeah, I know that. I don't feel anything.
S3. Come on.
Well,
I got you. S4. Nice. That's where we're going to start, sir. Now, let's check the shoulder. Oh, I forgot you came for a shoulder, didn't you?
Did.
Let's check it out. Look. That's the pop you're talking about, right?
Grinding.
That's the scapula. And that's also part of the function of the spine, but we're going to wait on that.
Okay.
Okay, I don't want to be premature and start just cracking everything, especially you know your body.
Yeah.
And we got the power on first, okay? You're going to do lots and lots and lots of walking. Go on your back. I will check your ankles. Bend the knee, patellar tracking. Es bueno. Valgus stress. I'm not worried about the tight right now.
Okay.
More of the clicks. That's good. Check the other step. Bend. Don't be scared, dude.
I am.
Don't be scared. I saw it right in your eyes, dude. Stop it. No fear. Look, dude. Tell me.
It's just tight.
Tight is what different, dude. I'm talking about clicking first.
Well, the last time it clicked was right before we started. I had to like go like that with my left knee, and then it popped.
Okay.
I don't feel anything yet.
Okay. Keep it bent. Now, I'm going to do, before I start all that, I want to do a little buff and polish on the hip. And this is the bursa, right? You got bursas that sit there to prevent friction. These bursas are tiny little bit swollen.
Okay.
Bring your knee up to your chest, bring it up, and get straight.
Straight like that?
Straight that way, sorry. Down, knee to the chest.
Right one?
No, knee to the chest, foot to the floor. 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 2 more. 1 more. Now let's do the ankles. You got the full overhaul today, dude. Nice. Raise your right leg. Raise your left leg. There you go. Awesome. Stand up and walk it off, please. Do-do. Okay. Keep going. What's different now? Tell me everything that's different from when you came in. You got a little movement in those dimples now.
Yeah, I feel more movement.
Let me just tap
Feel
it back.
smoother.
A little smoother.
Yeah.
I'm not worrying about the ankles or joints popping right now, okay?
Okay.
Walk, please. Yep. We got the movement. Go ahead and sit on the floor, bend the knees. No kidding.
A lot easier.
Good stuff. Okay, stand up, please. Check the hands. Squeeze the hand. What was your position in baseball, by the way?
Outfield.
Outfield?
Yeah.
Left, right. Left, right. Squeeze. Hi. Squeeze. Elbow. Posterior ulna. Posterior lunate. Posterior radial head. Posterior lunate. thumb. Turn this way, please. We're gonna do the ears. You're all set, brother. Questions for me?
All good. Appreciate it.
Welcome to the office.
Thank you.
I'll see you in a couple of days.
All right.